work, to function under the stress of sitting in the exam hall, ability to use your mind to get those questions correct. So more than the knowledge, studying wala part, reading ka part, slogging, rote learning, that a lot of you can do. But can you convert that learning into the correct answer for the question that you are attempting? That is what decides whether you pass or you don't pass. है ना? So all the studying for 6 months, for years, that's on one side. And doing those 300 questions in that exam hall is a completely different ball game. So for that, we have these practice sessions, like we have these exams, the test that we hold regularly, and we also have the GTs that we do regularly. So today we have the All India mock GT from the DocTutorials. I would want all of you to attempt the exam, not today. Today you have to sit with me for the dermatology session, but the test is live for 72 hours on the app. So 72 hours, you have to give the exam. A lot of good dermatology questions I've put in that also, and I've not repeated those in the MIQ today. So the 6, 7 derma questions that are there in the mock GT, I have not repeated those questions in today's exam. So I will say these are the most important questions, and those are also the most important questions. So please make sure that you give the GT not just for derma but for practicing the whole setup of the exam that you can. So should we start? When you all gave the test, did you find the exam easy or you found the exam difficult? Did you find it easy? It was okay. What about others? What was your experience? What was your experience? What about others? Easy, very good. I love that you find it easy. That's what is required. You have to be able to solve the questions. That does not necessarily mean that the paper is easy. That just means that you know your subject. So I am happy if you find it easy. I'm happy if you find it medium. I don't want anyone to be finding it difficult. Exam questions actually are not difficult when it comes to derma. They are moderate to easy questions. All that you have to do is know the subject to be able to answer them. Anyone else? Who all will tell me how did you find the exam? I've got a few easy, I've got a few moderate. I hope nobody found it difficult. Okay, so let's begin. Let's begin. Question number 1. This is a very, very, very favorite of the exams, and I would say this is the very favorite of the INI exam. Very favorite. Tell me, what is the that's what the exam is. Options are very near, so you have to be able to rule out the options. So when you look at this image, what do you see? See, with this image, I will also be doing the question that this image is, the diagnosis that this image is, because this was asked in the FMG Jan 26 paper. Same disease. So I've just put that as an image here so that I can also tell you about the lesions, but this same diagnosis was asked in your recent FMG January 26 paper. What you see here is a lesion which has a prominent margin and there is nothing in the center. So this prominent margin without having anything in the center, what is this shape? This is like a ring. This is a ring-shaped lesion. Ring-shaped lesions are also called as annular lesions. So what is this? Amongst the options, annular, discoid, targetoid, bullous, very close options. I would say these three are very close. For someone who doesn't know, these three are very close. But now I'm telling you, this is a ring-shaped lesion. So this is a annular lesion. If it was a round lesion, but not having any prominent margins and having the disease all over the surface of the lesion, then this would become discoid lesion, which are also coin-shaped lesion. The only thing is that these are round. You have the disease process all over, just that the shape of the lesion is round. They are called as discoid lesions. And what are targetoid lesions? Targetoid lesions have different colored rings. So they have concentric rings. There is no margin here. So these, when it is three concentric rings, this is erythema multiforme, which was again a question in your January 26 FMG paper. So in this same question, we have two diagnoses that were asked in your January exam. First is erythema multiforme. Here we would have three concentric rings. I have image of erythema multiforme later in one of the questions. So this is just to tell you, when there are three concentric rings, it's erythema multiforme. When it is ring shaped, it is annular. When it is round, disc or a coin shaped, then it is discoid. I hope this is clear to all of you. So these are the different morphologies that we have in the skin lesion. The correct answer here is option A, that is annular. Bullous is very easy. Bullous is fluid filled, so this will be a fluid filled lesion more than 1 centimeter in size. This is definitely not bullous. So clear to everyone, this was the annular lesions. Now, what are the common annular or the ring-shaped lesions in dermatology that you should be knowing for your FMG exam? First is borderline leprosy, where you have these ring-shaped annular lesions which have the Swiss cheese appearance, the inverted cup and saucer appearance. Then we have the granuloma annulare, which, as I told you, was a question in your January 26 paper, generally seen in diabetics on the hand. It is asymptomatic, non-itchy lesion. Asymptomatic means it is non-itchy. So generally seen in diabetics on the hand, it is non-itchy, which is what differentiates it from the fungal infections, that is the tinea. As I always tell you, tinnias are always itchy. So if a question says asymptomatic, it is trying to take you away from the tinnias. And this will be a skin colored lesion. It will be a skin colored annular plaque with normal skin in the center, no redness, no scaling. So this is what is granuloma annulare. The shape is annular, the histopatch shows granuloma, the name of the disease tells you what you are dealing with. So is this clear? With this, we also do granuloma annulare, which was asked in your January 26 paper. And another annular lesion is pityriasis rosea with this peripheral colorative scale. This also we'll do later. Tinea, I'll show you later. So for now, these are the annular lesions that you have to understand. You mean to say erythema annulare chronicum satya by migratory? Do you mean to say erythema annulare, uh, erythema chronicum migrans, which is seen in erythema chronicum migrans, which is seen in Borrelia infections, that is the Lyme disease. Is this what you want to say? Yes, this is also an annular lesion. So that's one more example of annular lesions. Then these are the discoid lesions, which are round, which are coin shaped. Nomular eczema is just eczemas which are round in shape. Then discoid lupus erythematosus, which is the chronic cutaneous lupus erythematosus. This also has the term discoid in its name because the lesions are round, they are coin shaped. When this happens in the scalp, this causes scarring, alopecia. And what is one sign with DLE? Who will tell me what is the sign with DLE? We did this in the class that day. What is the sign with DLE? This is a INI November 25 question. The sign with DLE. What is the sign with DLE? Carpet tack sign. So remember, the sign with DLE is the carpet tack sign. So these are the discoid lesions, and one just for fun I've added. There are lesions which are also serpiginous, which are like a snake. So what is this lesion that looks like a snake? This is cutaneous larva migrans. This shape is called as serpiginous lesions. Okay? Good. Now coming to question number 2. A 30-year-old woman presented with complaints of excessive hair fall since 1 month. She is currently on chemotherapy for endometrial cancer. What is the diagnosis? So, a similar question to this was asked in your January 25 FMG paper. Similar question to this asked in the January 25 paper. First of all, the thing that you have to see is there is excessive hair fall. There is no pattern mentioned here. So this is diffuse hair fall since a short history of 1 month. So when a question says diffuse hair fall, the answer is going to be either anagen effluvium or telogen effluvium, right? When you look at the options, telogen effluvium is in the option, alopecia totalis. Totalis also means all scalp. So could this be alopecia totalis? Could this be anagen effluvium? Could this be androgenetic alopecia? No, it is not androgenetic alopecia. Androgenetic alopecia is patterned hair loss. We don't have patterned hair loss happening here. So one option we are able to rule out. Now, how do we rule out alopecia totalis? Who will tell me what is alopecia totalis? Alopecia totalis is a type of alopecia areata which is affecting the total scalp. So this is a type of alopecia areata which is affecting total scalp. Here it has no relation to cancer chemotherapy, it has no relation to any other trigger. So here scalp is going to be completely clean with complete alopecia over the scalp which develops over a few days. So this is not related to chemotherapy. This is not alopecia totalis. Now, how to choose between anagen effluvium and telogen effluvium? How will you choose? Like this. If a question says patient has cancer chemotherapy, then you go to anagen effluvium. You just have to be knowing the keywords that you have to catch. If the question says cancer chemotherapy, hair fall has started within a very short span. Here also it has happened within 1 month. She started chemotherapy. Patient goes completely bald. Even though this is not mentioned in the paper, even though this is not there in the image, but what we have in the question is patient is on chemotherapy for cancer. So when it says chemotherapy for cancer, you have to go to anagen effluvium, making this the correct answer here. On the other hand, if the question would have said patient has sudden diffuse hair fall, but that has started after a gap of 3 months from a trigger that is mentioned in the paper. Then you have to go to telogen effluvium. So here it has to mention a gap, means trigger is here, hair fall starts after 3 to 4 months. What are the common triggers? Sorry. What are the common triggers? First of all, delivery of a baby. So the question will say a lady who gave birth to a baby 4 months back now presents with excessive hair fall. Now presents with excessive hair fall. A lady or a patient who suffered from dengue 5 months back now comes with hair fall since 1 month. Suffered from COVID 8 months back, has hair fall for 4 months. This is all the kind of scenarios that you get for this. But the most important hint is this gap. If this gap is mentioned, it is telogen effluvium. If cancer chemotherapy is mentioned, this is anagen effluvium. Can you tell me what is the treatment? Treatment for both is none. We don't need to treat them. They both are self-limiting. So that's another important point that you need to know. Both are self-limiting. We don't need to treat them. Coming to this question, correct answer, as I already told you, is anagen effluvium, because here we have the term chemotherapy in the question. Question number 3. A 6-year-old child presents with patchy hair loss with scaling. Bedside test shows the finding below. What is the causative organism? So what is the question here telling us? First of all, question here is telling us that this is patchy hair loss. Patchy hair loss in a child. So when it says patchy hair loss, that too with scaling, you have to start thinking of tinea capitis. So thankfully, the question here is not asking us the diagnosis, it is just asking us the causative organism. So we already know that this is tinea, a child with patchy hair loss with scaling. Bedside test in tenias are KOH. So this is an image of the KOH. In the KOH, what do we see? We see that this is the hair shaft, and around the hair shaft, we see these fungi. So where are the fungi? The fungi are outside the hair shaft. The fungi are outside the hair shaft. And when it is outside the hair shaft, what is the type of infection? This is the ectothrix type of infection. And when this is ectothrix type of infection, what is the mnemonic that comes? Mnemonic that comes is GMC, because C here is the C of the ectothrix. So this is the C of the ectothrix. Now it is asking us what is the causative organism. So what is the causative organism when it comes to GMC? Grey patch, microsporum, ectothrix. So M here is the organism that causes this infection. Look at the options. Trichophyton violacum is the causative organism for black dot tinea capitis. In fact, it is the most common cause of tinea capitis in India. So remember, most common cause of tinea capitis in India is Trichophyton violacum. Trichophyton chandonii causes favus. Microsporum canis is the one that is a microsporum. This causes the grey patch. Trichophyton rubrum causes tinnias which happen on the skin like tinea corporis, tinea unguum of the nail. It does not often cause hair infections. So this is not implicated in hair infections. Now, this is a tricky question because if instead of ectothrix, it was giving you endothrix, for endothrix, you would have gone to BNT, you would have gone to trichophyton, and then you would have gotten confused between violacum, chandonii, and rubrum. So that is where the confusion would have come. So please remember, even though this is trichophyton, chandonii is only for the favus. Rubrum does not become a very common cause for scalp infections, although it is most common cause for the rest of the skin. It is violacum that you would mark if this was endothrix. Is this clear to everyone? So if instead of ectothrix, I would have put endothrix in the option, then your answer would have been violacum. Don't go on to marking chandonii for that. Is this clear? This gets a little bugging, but is that clear? Just look at the hair shaft. If the spores are outside the hair shaft, this is ectothrix, which is the GMC. If the spores are within the hair shaft, then this is endothrix. Then your mnemonic becomes BNT. This is the black dot variant caused by Trichophyton violacum and Trichophyton tonginens. These are the only two species that you have to remember with respect to black dot. This question was there in the NEET PG 2024. You had to identify the causative organism by seeing that this was an endothrix infection. Favus by chandonii. Chirion is caused by zoophilic organisms. So you can have history of pets in the question. The most common organism is Trichophyton mentagrophytes. This would be a red boggy swelling, minimal pain with pustules with lymphadenopathy. What is the next investigation in all these tenias? KOH, where you see the fungi. Wood's lamp is pale green. This is positive in the grey patch variant. This gives pale green fluorescence. Treatment of choice, glycyrfulvin, given for 4 to 6 weeks. Is that clear? Then we come to question number 4. A 15-year-old girl, so this is a teenager. Let's wait. Meanwhile, read the question with me. Meanwhile, read the question with me. A 15-year-old girl presents with abdominal pain, nausea, vomiting On examination, irregular patchy hair loss on the scalp with broken hair of different lengths, follicular hemorrhages is noted. Barium meal study is shown below. What condition is this? Tell me what is the diagnosis. Tell me what's the diagnosis. First of all, when it is pain, nausea, vomiting, what do you have to suspect? You have to suspect GI obstruction. And in the barium meal also you see something obstructing the stomach here. So we know we are dealing with GI obstruction. Now on examination we see irregular patchy hair loss with broken hair. So when you have patchy hair loss with broken hair of different lengths with perifollicular hemorrhages, where do you go? You go to a diagnosis of trichotillomania. You go to a diagnosis of trichotillomania. Now, these trichotillomania patients can sometimes eat the hair. This hair can get accumulated in the stomach. When it gets accumulated in the stomach, this causes formation of a trichobezoar, which can present with findings suggestive of GI obstruction. So, what is the category of the disease that does this belong to? Is this an excoriation disorder? Excoriation disorders may patient does itching. So these are disorders like prurigo simplex. These are disorders which are not related to hair. Is this obsessive compulsive disorder? Is this dermatophyte? Is this autoimmune? Dermatophyte is fungal. This is tinea capitis. First of all, tinea capitis will not happen in a 15-year-old. Tinea capitis will not present with broken hair. It will present with scaling and itching. So this is also out. Follicular hemorrhages is trichotillomania. Trichotillomania is not an autoimmune disease. This is an obsessive compulsive disorder. Autoimmune disease is alopecia areata. Alopecia areata would be a clean patch with complete hair loss, not the broken hair of different lengths and that. So we know that we are dealing with trichotillomania. Trichotillomania is an obsessive compulsive disorder, making option C the correct answer here. See, this will be a patch with broken hair, patch with broken hair of different lengths, and when you look closely, you see these perifollicular hemorrhages. Treatment of choice, cognitive behavior therapy. If you have to give medicines, drug of choice is the SSRIs. Since a lot of these patients also suffer from stress, anxiety, depression, they tend to have other features. Due to the stress, they can sometimes eat the hair. Eating the hair leads to trichophagia, which can lead to formation of trichobezoar that presents with features of GI obstruction. Is that clear? Good. Now, question number 5. A 19-year-old boy has these lesions on the face. What is the primary lesion of the disease? Now this boy's face is completely clear, but this is his picture 2 months into treatment. So this is what he was even 2 months into treatment. What do you see here? You see these nodulocystic lesions, you see pustules, you see papules, and you also see comedons. So what we see here are nodulocystic lesions, pustules, papules, and comedons. Even though you cannot make out comedons in the picture, that's a little difficult for you. But if you just look at this diagnosis where you see these nodulocystic papulopustular lesions, what is your diagnosis? Your diagnosis is acne vulgaris. So most of you should be able to make this diagnosis of acne vulgaris, but the question is not asking us the diagnosis. It is asking us what is the primary lesion. So what is the primary lesion of acne vulgaris? This is a question which came in the July 23 FMGE exam. A lot of students ended up marking pustules or nodules as the primary lesion. But please remember, whatever is the morphology that you see, the diagnosis is acne and primary lesion is always going to be a comedon. Yes, you see all of them as we can see in the image, but that's because acne as a disease has pleomorphic lesions. You can see different stages of the disease at the same time. But the primary lesion, the starting lesion, remains a comedon. So your correct answer is option A. Very good. All of you have gotten it correct. And please remember, another question that can come from acne is that this is a disorder of pilosebaceous unit. It is not just a disorder of the sebaceous glands, it has hair as well as sebaceous glands. Primary lesion will always remain a comedon. When you get this kind of an image, this is an image from your August 2020 FMG exam, you have predominant comedons in the image. Treatment of choice is going to be topical retinoids. When you have nodulocystic acne, treatment of choice is going to be isotretinoin for these patients. So these are the two scenarios where you can be asked treatment of choice, topical retinoids for comedonal acne and oral retinoids for nodulocystic acne. Then an often asked question, what is the most important toxicity of oral retinoids? Most important adverse effect that you have to remember is teratogenicity. Then you are asked, what is the blood test that you have to do for monitoring? Liver function test and lipid profile, because they can lead to raised liver enzymes, it can lead to raised triglycerides. Then what is the bacteria responsible? It is Propionibacterium acnes. These are all the questions that you can get with acne in a patient. Now question number 6. A 32-year-old female presents with recurrent painful lesions as shown. What is the pathology of the disease? So what you see in the image are these reddish lesions, which are nodules. So you see nodules, which, as the question says, are painful. Then you also see these bridging scars. Bridging scars means they are connecting one nodule, one sinus to another. What is your diagnosis? Your diagnosis by looking at this is hidradenitis suppurativa. Your diagnosis by looking at this is hidradenitis suppurativa. If these were skin colored papules in the underarms, skin colored papules would be Fox. For Dicey disease, if these are painful nodules, this is hidradenitis suppurativa. HS, is that a disorder of eccrine gland blockade? No. Eccrine gland blockade is malaria. Apocrine gland infection? No. Hair follicle and apocrine gland occlusion? Yes, that is what happens in HS. HS is a disorder where there is blockade of the hair as well as the hair follicle gland. Sebaceous gland hypertrophy? No. So what is the correct answer here? Correct answer is hair follicle and apocrine gland occlusion. HS is also called as inverse acne. You see this in the axillary nipple and the groin, and the main diagnostic feature is painful nodules, abscesses and scars. Treatment for HS, we initially start with antibiotics like doxy. If that does not work, we can go to oral retinoids. If that does not work, there are some biologics like TNF alpha inhibitors, interleukin 17 inhibitors. If that also does not work, then we just do a ablation of the whole axillary skin, because this is where your apocrine glands are present. So all that we have to do is we just have to remove this whole skin. Just remove it. We do a CO2 laser ablation of this whole area. If it is very severe with a lot of sinuses, then what the surgeons do, they do remove the whole axillary triangle from this area, the skin over that, because the only solution is to remove the apocrine glands. There is no other solution. Yes, someone raised their hands. What is the doubt? What is the doubt? Who raised the hands? Any doubts? Is hidradenitis suppurativa clear? I just want you to be able to differentiate this from Fox-Pedicy disease, which would be itchy, skin-colored papules in the axillary nipple and the groin. That is something that you should not be confusing. Question number 7. A patient presented with erythematous plaques covering more than 50% body surface area. On examination, following finding was observed, which is not used for treatment. So question is asking us which is not used for treatment. What is not used for treatment here? First of all, tell me what is the diagnosis. Erythematous plaques can be anything and everything on this earth. There are hundreds of skin diseases which come with erythematous plaques. So erythematous plaques is not telling us anything. We have to now come to the image. In the image, what do we see? In the image, we see that there is a lesion which has a lot of silvery white scales. And in the center, we see an area which shows an erosion or a scratch. And in that erosion, there is pinpoint bleeding. So, what is that disease which has silvery white scales, which on scratching shows pinpoint bleeding? Yes, this is a case of psoriasis, which is showing us Auspitz sign positive, which is showing us Auspitz sign positive. And when you have made your diagnosis of psoriasis by identifying the Auspitz sign, let us now come to the question which is not used for treatment. Is phototherapy used for treatment? Yes. Is prednisolone used for treatment? No. Prednisolone is a oral steroid. And I told you many a times during the class, we absolutely don't use oral steroids in the treatment of psoriasis. Acetretin is an oral retinoid. This is used. Methotrexate, of course, is used. So first of all, in this question, identify that they are asking you about psoriasis. And second thing that you should know is steroids are not used in the treatment of psoriasis. And what is this test in which you see the Auspitz sign? The test is the Grittage test. This has been asked in your January 25 FMG paper. This has recently been asked in the INI in November 25. So two exams in the same year asked the test for psoriasis. The test is the Grittage test. The finding is the pinpoint bleeding, which is the Auspitz sign. The psoriatic lesions will show you silvery white scaling on the red plaques. Another named finding that you have to be able to identify if it comes as an image, because this has often been asked as images. It has also been asked in the FMG exam 2021, Kobner's phenomena. Kobner's phenomena is appearance of new lesions at sites of trauma. This is a very, very important image to identify. You will see lesions that are linear. And Kobner's is of two types, true Kobner's, pseudocobnus. True cobnus is seen in autoimmune diseases, psoriasis, lichen planus, vitiligo. Pseudocobnus is seen in cutaneous viral infections, that is in molluscum contagiosum and viral warts. Is that clear? So true cobnus, topical steroids we use. Yes, Shriji, topical steroids we use. I'll come to that. But oral steroids we don't use in psoriasis. So prednisolone is an oral steroid. Please see what the question says. It is saying prednisolone. Prednisolone is an oral steroid. We don't use oral steroids. Anyways, cobnus clear? Do you know causes of true cobnus and pseudocobnus? True cobnus is psoriasis, lichen planus, and vitiligo. Pseudocobnus is molluscum and viral warts. Now coming to treatment, see this is a very important point to know. Topical steroids are used, but we don't use oral steroids. That is a very important difference that you have to remember. Why topical? Because topical steroids will, psoriasis is an autoimmune disease. Topical steroids are important. They will cause immunosuppression on the lesion topically. We can use topical steroids, but oral steroids, initially for 1 or 2 weeks, they will tend to reduce the psoriatic lesions. But as you stop the oral steroids, patient can go into a flare-up, patient can develop pustular psoriasis. So oral steroids are not at all given in patients with psoriasis. Only indication for oral steroids is if a patient is suffering from impetigo herpetiformis. This is the only time we give steroids in a patient with psoriasis. Otherwise, the drug of choice for most of the patients with psoriasis, especially when body surface area is more than 10%, then this is chronic plaque psoriasis. For psoriasis with psoriatic arthritis, this question has been asked to you in the FMG exam. If a patient is suffering from psoriasis with psoriatic arthritis, the drug of choice is methotrexate. For pustular psoriasis, acetretin. This question has never been asked, but if a question specifically says which drug acts the fastest, which is the drug for rapid relief, then you have to be giving this. Is that clear? So, is that clear? Clear, not clear? So topical steroids can be used, but oral steroids are not used. Other drugs are vitamin D3 analogs. Tazarotene. Tazarotene is a topical retinoid. Coal tar and Thrillin, these are also used. Question number 8. A 20-year-old, oh, that's not a 20-year-old child. Please strike that out. A 20-year-old patient presents with patchy alopecia, nail findings as shown. What is the diagnosis? So, this 20-year-old patient is coming to us with patchy alopecia. This is the third question with patchy alopecia. One we had patchy alopecia with tinea capitis. One we had patchy alopecia with broken hair, that was trichotillomania. And this is the third patchy alopecia that we are having. But this alopecia has nail changes. So what do you think is the correct answer? What do you see on the nail? Just zoom it. I don't know how much you can zoom in your exams, but if you zoom it here, you see these pinpoint depressions on the nail surface. These pinpoint depressions are arranged in a regular manner on the nail. So when this is arranged in a regular manner on the nail, what is this? This is regular pitting. So we have the depressions, which is pitting, and then we see the pattern of pitting. This is regular pitting. When you have regular pitting plus patchy alopecia, what do you have to think of? Very simple. I don't have to even look at the options. The correct answer here is alopecia areata, because this is the one that comes with regular pitting. Moth-eaten alopecia is seen in secondary syphilis. It will have skin features, but it does not have any specific nail findings. So this is out. Psoriasis will have nail findings, but this will be irregular pitting, and there is no alopecia in psoriasis. So it is out. Even if you cannot make out pitting regular, irregular, by alopecia you should be able to rule out steroid. Tinea capitis will have alopecia, but in the nail there is going to be no pitting. So this is also out. See, in every question I want to tell you how to rule out the options also. Because when you give an exam, there are questions that you know. There are answers that you know. But for all the questions which you are not sure, it is important to be able to eliminate other options, because that is what gives you a little more possibility of coming to the correct answer. You have to be eliminating. That increases the chances of even your guess becoming, more correct. For every option that you eliminate, if all four options you are not sure at all what to eliminate, if you are not sure at all, then there is a 25% chance that your guess is correct. But if you rule out one option, 33% chances of getting it correct. If you're choosing just between two, 50% chances of getting correct. So for all questions, please learn to rule out options. You still have 20 days left to the exam almost. So if you still, while practicing as many MCQs as you can, you learn to rule out options, you increase your chances of even getting your guesses correct. That's very, very, very important. So this was alopecia areata, patchy alopecia, but this is complete alopecia, smooth bald skin. You see exclamation mark here, and in the nail you see the regular pitting or the geometric nail. So this geometric nail is what takes you to alopecia areata. And if this was psoriasis, look at the pitting. The pitting here is irregular. So the most important thing in a psoriatic nail is irregular pitting. As I told you during the CPR discussion also, this question was asked in NEET PG 21, where they gave an image of a nail with pitting. They asked you to diagnose whether it was psoriasis, whether it was alopecia areata. So just look at these two together. If there is regular pitting, then this is alopecia areata. Even if they don't mention alopecia, in that question they didn't mention alopecia. They just gave an image of nail and they asked the diagnosis. So if alopecia is mentioned, it makes your job easy. You go towards alopecia areata. But if alopecia is not mentioned, then you look at the type of pitting. If it is regular pitting, then this is areata. If this is irregular pitting, then this is psoriasis. I hope I am clear. Then this is the salmon patch. which is the most specific finding. This is the orangish, reddish orange color that you have in the salmon fish. That is why it is called as the salmon patch, also called as the oil drop sign. So these are findings of nail psoriasis. Another image that you have gotten in your June or your December 22 FMG exam was the subungual hyperkeratosis in the psoriatic nail. So please remember, you can get image of pitting, you can get image of salmon patch, you can also get image of the subungual hyperkeratosis, which is scaling under the nail in a psoriatic nail. About the other options that you can get with respect to nail, this is pterygium. This is the wing-shaped fold which you see in lichen planus. Then in onychomycosis, there would be a discoloration of the nail. Okay, so these are other pictures that you can get from the nail. Identify this wing-shaped fold. Identify the discoloration of onychomycosis. Coming to question number 9. A 45-year-old female presents with burning sensation in the mouth, especially while consuming spicy food. Oral examination reveals the lesions as shown. What is the diagnosis? So the question here says that this lady has burning sensation on the mouth on eating hot spicy foods. Okay. Now when you look at the image, what do you see? Actually, an image of tongue with this is an old, although this is a new patient of mine, but a question similar to this was asked in AIMS 2017 exam. What do you see here? You see these lacy white reticulate stria. Lacy white reticulate stria. So what you see are these lacy white reticulate stria in the image. And in the center of a few of these lesions, there is a erosion. So when there is erosion in this lesion, the lacy reticulate stria tells us that this is oral lichen planus. And when there is erosion, it tells us it is the erosive variant. This erosive variant presents with burning sensation, especially on eating hot spicy food. So what is the correct diagnosis here? Correct diagnosis here is oral lichen planus. Very simple. It is the image that is giving us the diagnosis, not from the text. See, aphthous ulcer would not come with burning sensation. Means patient will come with burning sensation, but on examination, you would see ulcer, which will be well defined, and it will have a yellow necrotic slough on the surface. So aphthous ulcer would be an ulcer. It would not be lacy reticulate stria. Leukoplakia would be a white patch which is uniform. Plus there may be a history of either gutka or chewing tobacco or smoking. For oral candidiasis, again, it would be a white patch which can be scraped, but it would not be the lacy white reticulate stria. This is the oral lichen planus where these stria give you a diagnosis of LP. Is that clear? So correct answer here is option A. For lichen planus, there are certain points which are often asked in the exam, so I want you to know. First of all, this is an autoimmune disease. An infection that can trigger it is hepatitis C. This question has been asked in the INI 21. So remember, dental amalgam, although no longer used these days, but this is also associated drugs 25. So in the NEET PG 25, they gave an image of oral lichen planus and they asked what is the drug that the patient has taken which can exacerbate it. So remember, the drug that the patient takes is beta blockers or ACE inhibitors. Then antimalarials, isoniazid, these can also contribute. When you get an image, it is the lacy white reticulate stria in the image which take you towards lichen planus. Here also you see the lacy white reticulate stria. Only difference is that there is an erosion in the center of this. This erosion is what is the erosive lichen planus. Patient here presents with burning sensation. Remember, there can be a risk of malignancy developing in these lesions over time. What are these lacy white reticulate stria called? These are called as Wickham's stria. Is this clear? Is the image clear for all of you? Is the image clear? Lacy white reticulate striae in the oral cavity, oral lichen planus. These are all very, very, very important questions. These are all very important questions. So reticular OLP is generally asymptomatic. We just look at it when a patient comes to us. Erosive is where the symptoms happen. If it was an image of skin lichen planus, you would see these purple pruritic papules. For nail, I've already shown you the image of pterygium. This is another image of pterygium. In the scalp, lichen planus causes scarring alopecia, which is called as lichen planus pilaris. So you can get this as an image, which is often asked in the exams. This can also be asked. This can also be asked. So these are the different images that you can get with lichen planus. And see, this is the image of the aphthous ulcer. There was a time from 2015 to 2019. This was asked in almost every alternate FMGE exam. An image of the aphthous ulcer. So I've just put it here. This is a painful ulcer, which is well defined, which has a yellow necrotic slough on the surface, can have surrounding erythema. So this can also present with burning sensation, but the findings are different. Coming to question number 10, all are neutrophilic microabscesses except. All are neutrophilic microabscesses except. बताओ भाई, tell me. बताओ. Very good. Very good. I'm getting the correct answer. Very good. Kogoch, spongiform pustules. These are neutrophilic. These are seen in stratum spinosum in case of psoriasis. Monroe's microabscesses. These are also neutrophilic, seen in stratum corneum in a patient with psoriasis. Papillary tip microabscesses, these are also neutrophilic. These are seen in patients with dermatitis herpetiformis. But Portreous microabscesses, these are intraepidermal lymphocytic abscesses, which are the cancer cells which enter the epidermis, seen in patients with mycosis fungoides. So all of these are abscesses, but the one that is not neutrophilic is Portreous abscess because this contains lymphocytes. So the correct answer here is option B. Very good. Coming to question number 11, a 19-year-old male presents with multiple erythematous scaly lesions on the trunk, proximal limbs. There is no involvement of palms and soles. There is no systemic symptoms. What is the diagnosis? So the text in itself is quite sufficient in making the diagnosis, but we also have the image. What do we see in the image? In the image, we see these red scaly lesions, a few of them with a little wishful thinking. Thoda sa imagine karo. You see these lesions arranged in lines on the trunk. So what is this pattern? What is this pattern? This is your Christmas tree pattern. This is on the trunk. This is red. This is scaly. So that is something which is seen in pityriasis rosea. It is on the trunk and the proximal limbs. Yes. There is no involvement of palms and soles. Yes. There is no systemic symptoms. Yes. Now, why this mention of no involvement of palms and soles? This is a very important thing because when a patient comes to us with these kind of rashes on the trunk, even in the clinic on a daily basis, when I see these kind of patients, I always examine their palms and soles because these are all young teenagers. They can have certain experiences which can lead to what is secondary syphilis. So this kind of a red rash on the trunk, if I can't make out the Christmas tree appearance, if you can't make out the Christmas tree appearance in the image, then you should also be confused. You should be thinking of secondary syphilis here. But no palms and soles is what takes you towards secondary, takes you away from secondary syphilis. So this is out. Now, pityriasis versicolor is also seen on the trunk. But is this red scaly? No. These are hypopigmented scaly lesions. So please remember, even though they all sound similar, pityriasis versicolor, pityriasis rosea, pityriasis rubra pilaris, but they all are very different. Basically, this term, pityriasis, means scaly. This term means scaly. So this just means scaly. This is not related to the color of the lesion. This is not related to anything else. It just means scaly. So pityriasis versicolor is scaly hypopigmented lesions. Pityriasis rosea is scaly red colored lesions. Pityriasis rubra pilaris is scaly red colored lesions around the hair. Pilaris means hair. So that's all is the similarity of pityriasis. It means nothing else. So here we see red scaly lesions in a Christmas tree pattern. The diagnosis is pityriasis rosea. You have to be able to rule out other options. That is very, very, very important. Okay, further strengthens your confidence. So pityriasis rosea, the first patch is the mother's patch or the Herald patch. Then you get these multiple lesions on the body in the Christmas tree pattern. When you look at these lesions, this is the classic scale that you see here, which is the peripheral colorate scale. So you can get an image of the Christmas tree pattern, you can get an image of the peripheral colorative scale. These are very, very, very important, and this is especially very, very favorite of the INI. So when this is a favorite of the INI, this can also be asked in the FMGE. So this is pityriasis rosea. Is that clear? Clear? Most important differential for you all, because they both happen on the back, they both happen on the trunk, is pityriasis versicolor. If you don't know the difference, you will be confused. But pityriasis versicolor is going to be hypopigmented scaly lesions. Yes, hyper bhi ho sakta hai, naam mein it is versicolor, they can be variable colors, but the image that you get is generally these hypopigmented scaly lesions on the upper back and the upper chest. So look at these two together. Pityriasis rosea has the term red. This will be red. This is versicolor. This is variable color. These can be hypo and hyper pigmented. Secondary syphilis can have a generalized rash on the body. Yes, it can have, but along with that, there will be these coppery brown scaly macules on the palms and soles. There can be condyloma lata. There can be moth-eaten alopecia. So here the whole clinical spectrum is going to be different. It is not just a Christmas tree pattern rash that you get. Okay, so asymptomatic rash can be here, but then no palms and soles is what takes you away from secondary syphilis. Understood? So the correct answer here is option B, that is pityriasis rosea. Question number 12. A 52-year-old man presents with a 6-week history of painful oral erosions, multiple flaccid bullae over chest upper back. Immunofluorescence findings are shown below. What is the diagnosis? So the question here is telling us that there are oral erosions with flaccid bullae. The minute the question says flaccid bullae, you have to think of pemphigus. The minute the question says flaccid bullae, you have to think of pemphigus. And when it says oral erosions, then this is pemphigus vulgaris. We don't even need the immunofluorescence here. But if you look at the immunofluorescence, you see the fishnet pattern here. So this fishnet pattern further just tells you that this is pemphigus, but it is oral erosions which take you to pemphigus vulgaris. So linear IgA disease would have tense bullae. Dermatitis herpetiformis, completely different. Bullous pemphigoid, again tense bullae. It is only and only fitting with pemphigus vulgaris. Is that clear? So this I want to tell you before we move forward. If a patient presents with bullae, first of all in the question, see whether it is flaccid bullae or tense bullae. If it is flaccid bullae, it is pemphigus. If it is tense bullae, it is pemphigoid. Then here look at the mucosa. If the mucosa is involved, this is pemphigus vulgaris. If the mucosa is not involved, this is pemphigus foliaceus. Is that clear? So this is how you approach these questions. With pemphigoid, this will generally be an elderly patient with itching and tense bullae. If it is a child with tense bullae, then this is linear IgA disease. Okay? If it is a child with tense bullae, it is linear IgA disease. And if it says itchy papillovesicular lesions, this is completely different. Papillovesicular lesions, then this is dermatitis herpetiformis. Is that understood? This is a very, very important approach. First of all, see whether it is flaccid or it is tense. Then you go to pemphigus or pemphigoid, depending upon the mucosa vulgaris or foliaceus. Is that understood by everyone? Is that understood? This is very, very, very important. Clear to all? And very, very, very different scenario is itchy papillovesicles. That will be dermatitis herpetiformis. So coming to the question here, this is pemphigus vulgaris. This is something that I've already explained to you. Flaccid bullae is common in both, but with mucosa is vulgaris, without mucosa is pemphigus foliaceus. Then there are clinical signs here. Nikolsky sign. These are positive in all. Pemphigus vulgaris and pemphigus foliaceus. Nikolsky sign is positive. Bulla spread sign is positive. These questions are often asked in the FMGE exam. So as options, so you should know Nikolsky sign is positive in pemphigus. Bulla spread sign is positive in pemphigus. Zank smear shows these round cells with a large nucleus. What are these? These are acantholytic cells. So these are round cells with large nucleus. These are acantholytic cells. DIF shows this fishnet IgG pattern. This is also seen in pemphigus. So are these four clear? Nikolsky sign, Bulla spread sign, Zank smear, DIF. These are all positive in pemphigus. You have to know the findings of Zank smear. You have to know the findings or the image of DIF. Then histopath. Not ever asked in the FMG exam, but you'd never know. In vulgaris, this is the stratum basale. The split is above the stratum basale. So this is a suprabasal split. In pemphigus foliaceus, this is the stratum basale, spinosum, granulosum, corneum. The split is just below the stratum corneum, which is your subcorneal split. So that's an important point. This has been asked in the NEET PG. This has been asked in the INI. So there is a chance that this can also be asked in the FMG exam. So this is very important for you to understand. In pemphigus vulgaris, there is a suprabasal split along with row of tombstone appearance. This is the row of tombstone appearance. You see that the basal cells have separated from each other, but they're still attached to the basement membrane. So this kind of appearance which you are seeing here, this is the row of tombstone appearance. These are very, very, very important findings of pemphigus vulgaris. For pemphigus foliaceus, the split is subcorneal. Is that clear? What again? What again? The histopath or the signs? What do you want me to repeat? What do you want me to repeat? Histopath. See, I'll just show you here. In pemphigus, if it is pemphigus vulgaris, pemphigus foliaceus. In pemphigus vulgaris, this is the epidermis, this is the dermis, this is the epidermis, this is the dermis. In pemphigus vulgaris, The split is going to be suprabasal. In pemphigus foliaceus, the split is going to be just below the corneum, which is subcorneal split. How do I remember this? This is F. F comes first, so it has the first desmoglein, desmoglein 1. And here the split also comes on the top, which is first. So on the top, the split is subcorneal. Are you understanding? Pemphigus vulgaris is V. V comes in the end. So it has the last desmoglein, which is desmoglein 3. And here also the split comes in the end on the bottom. So on the bottom, this is a suprabasal split. Is this clear to everyone? Is this clear? So this is how you remember. Although this has not been asked in the FMG exam till now, but you never know if this is asked. So this is the difference. Suprabasal split versus subcorneal split. Bullous pemphigoid will be elderly patient with tense bullae. So this is the tense bullae which we see in bullous pemphigoid. This is elderly patient with tense bullae with itching. DIF findings can be asked for bullous pemphigoid. Zhang smear findings can be asked. Zhang shows eosinophils. DIF shows linear IgG and C3 at the basement membrane zone. So these are two important points that can be asked. Bullous pemphigoid is very, very favorite of the FMG exam. So you never know what they ask you. Elderly patient with tense bullae and itching, with Zeitzmeyer showing eosinophils, DIF showing linear IgG3 at the basement membrane zone. This is all bullous pemphigoid. Question number 13. So what is this? A 28-year-old patient with chronic diarrhea presents with grouped papillovesicular lesions, excoriations on elbow, knee, upper back. Histopath findings are shown below. What is the next investigation to be done? So what I have done is I have combined. What did I tell you? What is itchy papillovesicular lesions? Itchy papillovesicular lesions is the only term that is mentioned for dermatitis herpetiformis. There is no confusion here. If a question says itch, this is an image which was there in your FFG July 24 exam. This image was given. I have not put it from somewhere. They have asked you this image. So what you see here is split, which is the empty spaces below the epidermis. So you see the subepidermal cleft or the split. And what you also see are papillary tip abscesses. This further tells you that your patient is suffering from dermatitis herpetiformis. So the skin diagnosis is clear that this is dermatitis herpetiformis. Along with this, patient also has chronic diarrhea. So what is this chronic diarrhea in a patient with dermatitis herpetiformis? What is a chronic diarrhea in a patient with dermatitis herpetiformis? What is chronic diarrhea in a patient with dermatitis herpetiformis? This is celiac disease. What is the investigation that we do in celiac disease? Anti-desmoglein 3. This is done in pemphigus vulgaris. Not here. It is out. Anti-tissue transglutaminase. In short, this is anti-TTG. Yes, this is done in celiac disease. Where is anti-Saccharomyces cerevisiae done? Where is anti-P-ANCA done? Tell me. Where is anti-Saccharomyces cerevisiae done? And P-ANCA. So these you have to read. This is your homework. Where is P-ANCA and this done? So this is the correct answer here is anti-TTG. This was the question that was asked in the NEET PG. If you're suspecting dermatitis herpetiformis, you know that patient may have celiac disease. You have to do for anti-TTG to look for causes of celiac disease. So this is a subepidermal immunobullous disorder. Target antigen is same as celiac disease. This is where it is common. This is the test that you have to done. Histopath shows the papillary tip abscesses. DIF shows the granular IgA at the basement membrane zone. See, I can speed up, but this is just a revision of what we did in the CPR. I want you to be revising along with this again. This is the only time that you are reading dermatology before your exam. So I would want you to do it in the best possible manner. But yes, okay, we'll speed it up. So this is granular IgA. Please remember the drug of choice is dapsone along with a gluten-free diet. Is that clear to everyone? This is dapsone with gluten-free diet. Question number 14. A full-term neonate has multiple flaccid blisters, area of skin peeling. There is no fever, no systemic illness. Mother has similar history in the sibling diagnosis. So what you see here is early onset. It is a neonate. Neonate comes with bullae, with erosions on feet, hands, buttock, and the umbilicus. So these are mostly the trauma-prone sites. Plus, there is family history in the sibling. So when there is a newborn who comes with history of trauma-induced bullae with history in the sibling, what is your diagnosis? Is this staphylococcal scalded skin syndrome? No. One, there would be fever. Two, there would be history of a localizing sign and symptom. Three, there is no family history here. So this is out. Pemphigus can happen in a neonate. Pemphigus can happen in a neonate, but only when the mother has pemphigus. So here mother does not have pemphigus. So this is also out. EB, neonatal herpes simplex. This is out. The correct answer for trauma-induced blisters is epidermolysis bullosa. This question is a recent INI May 26 question, so you should be very sure of it. This is epidermolysis bullosa. This is a mechanobullous disease, early onset, generally as a neonate. Patient comes with bullae at trauma-prone areas. Family history may be present. We do electron microscopy to diagnose this. So this is epidermolysis bullosa. Please rule it out from staphylococcal scalded skin syndrome. This is a very common cause of confusion for a lot of students because this also happens in children. They are generally seeing the images. They think it is staphylococcal scalded skin syndrome. But no, in staphylococcal scalded syndrome, this will be a baby with a history of localized staph infection. So you will be given a history of otitis externa or any such infection which is caused by Staph aureus, after which the baby will come with peeling of skin without any mucosal involvement. So in staphylococcal scalded skin syndrome, there will be localized infection, there will be fever. All of this will be together given to make you a diagnosis of S4. It will not be trauma-induced bullae. So most important thing is, see, the images are also similar. There is peeling of skin here, peeling of skin there, but you have to be able to rule it out. Question number 15. A patient presents with pigmented lesion as shown in the image. What is the diagnosis? So what do you see in the image? You see that this is a lesion which is having a midline demarcation. It is only on one side of the face. So this is unilateral lesion. What is the color of the skin here? It is blue-gray. What you also see is that the sclera is also blue. So when in a patient you have a unilateral lesion which is blue-gray, sclera is also blue. What is the correct answer? Is this nevus of ota, ito, melasma or the Beck's nevus? Tell me what is the correct answer? Very good. A lot of you have marked it correct. This is nevus of ota. This is nevus of ota. Why? Because this is blue-gray. A confusion would be I2, but I2 would be in the acromioclavicular area. I2 would not be on the face. It is ota, O for ocular, O for eyes. It is on the face. Melasma will be bilateral lesion. It will be brown. Becker's nevus is completely different. I will just show you. So this is ota. You have it as a unilateral blue-gray lesion with involvement of the sclera. So this is nevus of ota. Nevus of Ito would be on the acromioclavicular area. Melasma, this image asked in the July 24 FMGE exam, it will be bilateral brown in color. Becker's nevus will come at puberty. The background will be brown, but it will have dark black hair on it, and it can be anywhere on the body, not necessarily on the face. So this is not how nevus of Ota looks like. This is a Becker's nevus. It will be brown. It will have dark hair on the lesion. So this is Becker's nevus. Coming to question number 16. A 10-year-old girl presents with depigmented lesions with leukotrichia on right side of the face. Lesions appeared at 6 years of age, increased over 4 to 6 months. What is the diagnosis? So tell me, what is the diagnosis? A 10-year-old girl presents with depigmented lesions. So this is a child who has depigmented lesions with white hair within the lesions, that is leukotrichia. They came at 6 years of age. They increased over 4 to 6 months. So it was active only for a small period of time. What is the diagnosis? Is this hypomelanosis of Ito? No. Hypomelanosis of Ito comes at birth, and these are hypopigmented lines which you see in Blaschkoid pattern. So this is not hypomelanosis of Ito. Nevus depigmentosis, even though it says depigmentosis, these are also hypopigmented and they also come at birth. Piebaldism will be on the forehead again at birth, and it will not have leukotrichia. It will have a white forelock of hair, means hair above the lesion is going to be white. So we rule this out, we rule this out, we rule this out. The correct answer is segmental vitiligo, because this is how segmental vitiligo comes. It comes in the childhood, it rapidly increases over some time, it will have leukotrichia, and this is how it is going to look like. So it is only going to be on one side of the body. Because this is dermatomal, the lesions are going to be unilateral. So this is unilateral. This will have white hair in the lesion. It will increase over some time. So this is what is segmental vitiligo. Difference between hypopigmented versus depigmented. Hypopigmented, hypo means reduced. So this is reduced color. D means no. This is no color. So hypopigmented is going to be a light colored lesion. This is going to be a white colored lesion. This is a very important difference that you have to understand. Hypopigmented versus depigmented. Okay? For this image, see, segmental vitiligo is completely white. But if you look at nevus depigmentosis, here the skin color is just lighter. This is hypopigmented. Piebaldism is on the forehead with white hair on the top. Hypomelanosis of Ito is Blaschkoid white lines. So this is also out. Question number 17. An 8-year-old boy presents with lesions as shown in the image. What is the diagnosis? So 8-year-old boy with lesions. What are the lesions? We see these hypopigmented lesions on the face. So what is this boy with these hypopigmented lesions on the face, which are multiple? We can't make out the scaling, but we can see that these are multiple hypopigmented flat lesions which are macules. Is this vitiligo? No. See, this is another example of hypopigmented lesions. You see that the skin color is just lighter. It's not white. So vitiligo would be white. This is out. Post-inflammatory hypopigmentation, we need to have a history of some preceding lesion for us to call it as post-inflammatory hypo. So this is also out. Now you have to choose between P. alba and indeterminate leprosy. Indeterminate leprosy would be a single lesion. When it is multiple, you have to think of pityriasis alba. So the correct answer here is pityriasis alba. Is that clear to everyone? See, pityriasis alba will be in the child on the face as multiple hypopigmented macules with fine scaling. Again, it has the term pityriasis in it. Pityriasis, I told you, means scaling. So whenever you have the term pityriasis, it means scaling. So this is pityriasis alba. These are multiple scaly lesions. But if this was leprosy, this would be a single hypopigmented macule without any scaling, without any loss of sensation. So this would be a single lesion. Single lesion is indeterminate leprosy. Multiple lesions is pityriasis alba. Look at them together. So multiple scaly lesions is pityriasis alba. Single lesion, in this child, there will be history of the child belonging to the endemic area. This is what makes it indeterminate leprosy. Is this clear? The confusion here is generally between these two, and you have to be able to identify the difference. Question number 18. A 40-year-old farmer presents with recurrent pruritic lesions over the face, neck, and the hands for the past several months. Which of the following investigations is required to make a diagnosis? So, this is a farmer who presents with a recurrent itchy rash on exposed areas of the body, like face, neck, and hands. This is on the exposed areas of the body. So, can you tell me what is the diagnosis? Can you tell me what is the diagnosis? The diagnosis is airborne contact dermatitis. Airborne contact dermatitis is a type of allergic contact dermatitis. How do you make a diagnosis of allergic contact dermatitis? We don't do skin biopsy. We don't do IgE. We don't do skin prick test. The investigation of choice to make the diagnosis is the patch test. So here you have to understand, first of all, make the diagnosis. Diagnosis is airborne contact dermatitis because the farmer presents with an itchy rash on exposed parts of the body. This happens because of parthenium. And when you have to make a diagnosis is made using patch test, where you apply these patches on the back. You take a reading at 48 hours and then you take a reading at 96 hours. The principle that it follows is DTH, which is delayed type hypersensitivity. This is the type 4 hypersensitivity. Is that clear? For any and every case of contact allergic dermatitis, whether it is hair dye, it is nickel, it is cement, whatever, diagnosis is done using patch test. Question number 19. A 9-year-old child presents with recurrent itchy rash over the body. He also suffers from allergic rhinitis. What is the diagnosis? Question asked in the INI, question asked in the FMG. So last 6 months, this question has been asked in the INI, it has been asked in the FMG Jan 26, INI May 26. What is this? Child with a rash on the flexures. This is the popliteal fossa. Also suffers from an atopic disease, allergic rhinitis. What is the diagnosis? Correct. The diagnosis is atopic dermatitis. Seborrheic dermatitis would not be here. It will be on the face. It will have yellow, greasy rash. And this will be in the seborrheic areas. Airborne contact dermatitis, we just saw, will be a farmer with a rash in the exposed parts. Scabies will be completely different. There is no relevant of atopy or allergic rhinitis in a patient with scabies. So this is also out. The correct diagnosis here is atopic dermatitis. The correct diagnosis here is atopic dermatitis. Why does atopic dermatitis happen? Please remember, filaggrin deficiency. And the most important hint is the history of atopic disease. It can either be in the patient or it can be in the family. What are the histories that we can get? We can get either history of asthma, allergic rhinitis, food allergies. These are all the histories which, if given, take you towards atopic dermatitis. If they have to give you image, if they have to give you infantile AD, they will give you image of the face. If they have to give you childhood or adult AD, they will give you image of the folds because this is in the flexures. And Another image that can be asked from atopic dermatitis is these lines under the eyes that are the Denny Morgan folds. So these are the different images that can come from atopic dermatitis. Question number 20. A 5-year-old child presents with multiple hyperpigmented lesions over the trunk. So this is a child with multiple hyperpigmented lesions over the trunk. Rubbing a lesion results in formation of vein. What is this phenomenon called as? What is this called as? First of all, tell me what is the diagnosis. Child presenting with hyperpigmented lesions. When you stroke on the lesion, it leads to formation of a vein. What is the diagnosis? Diagnosis is urticaria pigmentosa. And rubbing a lesion resulting in wheal, this sign is called as the Darius sign. We just read the Kobnus phenomena, you would see linear lesions here. Nothing like rubbing leading to a wheal. Nikolsky we just see will be seen in pemphigus, where if you put pressure on the skin, that skin will peel. So that is what is the Nikolsky sign. So this is not the answer. This is not the answer. Scratch sign is seen in a patient of pityriasis. Versicolor, where when you scratch on the lesion, the scaling increases. So this is scratch sign. This is also out. The correct answer here is Darius sign. This was a question in the INI November 25. So you should be knowing Darius sign. Seen in a case of urticaria pigmentosa. Child comes with these kind of hyperpigmented lesions on the trunk. It is a type of cutaneous mastocytosis. When you stroke on this lesion with a pen, it leads to formation of this red colored wheal. This is called as the Darius sign. This is called as the Darius sign. So the questions that come in urticaria pigmentosa, number one, it is a type of cutaneous mastocytosis. Number two, the sign that is positive here is the Darius sign. Question, we'll take a small break now, 5 minutes, then we'll resume after 5 minutes. Okay? So we'll take a short 5-minute break. It is 11:30. We start at 11:35 p.m.